Hey guys, welcome back to Nurse Howie. I know it's been a while. Sorry about that. As you can probably tell, I've been pretty busy under the COVID regime. It's been a crazy pandemic, as you can also probably tell. You've probably been dealing with your own stuff. So a little catch up with me. I have been a travel nurse for the COVID pandemic, and I have helped out with the beginning of the pandemic in the LA area, and now I'm helping out with rural America in North Dakota. And the first day was not disappointing. It was definitely a tough one. It was like I would say it was an 18-hour shift for sure. Pretty much 2 out of the 3 of my patients were intubated, and again, it was a little bit of an adjustment for me because I'm a California nurse, and I'm used to having my 1-to-2 ratio law of having 2 patients for 1 nurse only by law, even in a pandemic. But everywhere else it doesn't matter. So I had 3 ICU patients, and one of them of course got severely hypoxic. They were all hypoxic really, but there were some different changes being a more experienced COVID nurse compared to these amazing nurses over here who are doing their best. But it's so crazy because the National Guard is here. I don't know what they do. Everybody is still very active, and you can see the bags under their eyes. Everybody's doing mandatory 16-18 hour shifts at least. So they're really happy to have travel nurses. They're not arguing about pay or anything like that, but they are ready to quit at any time. Families are yelling at us because they can't visit their family, and they don't understand that COVID is severe, but they do now, but they still don't. They're still trying to navigate the healthcare system, and so are the nurses and the doctors. So I really want to talk more about that later, but now I have to get back to work again because it's back to back 12, 14, 16, 18 hour shifts. So I will try to do my best to document the stuff, but one thing I'd like to mention is that yes, I don't really subscribe to low saturation levels anymore, because as long as the patient is not in distress, I don't worry so much, as long as the patient will recover. However, if the patient's saturation level does fall and it does not come back up within the next 1 to 2 minutes, then I start to kind of worry. And it's a lot better to know if the patient has a history of, let's say, an impending something like a pneumonia or pneumothorax or something like that. And now, apparently, like I learned yesterday, APE. And you really don't want to mess around with these D-dimers and inflammatory markers, because while we're busy worrying about pneumothorax and pneumonia and hypoxemia and whatnot, everything else is starting to crawl back up, just like, you know, PE is just what happened, because the doctor, as the anesthesiologist came in, or the anesthesia came in, they came in and did the ET tube. They intubated the patient who had no clue what happened, but she just kind of she peed because we gave her Lasix. We were trying to get the water out of her lungs, and apparently the nurse that was orienting me, she gave her a bedpan, and here's a clue. The previous nurse, the off-going nurse, told us that when she laid to a certain side, the patient would desat quickly, and the patient desats quickly already, so we kind of thought that it was an innocuous detail, but it was a very good, simple, subtle detail that didn't really come to mind until later on, because when the anesthesiologist came and intubated the patient, I asked her to put in a central line because she was already there, which is a good idea, because most likely the patient who is intubated is going to need some kind of sedation, so it's good to have a central line, because then they'll have pressors, because unfortunately they'll become septic. And there's another thing too, I'm now a proponent of late intubation. Try to postpone it as much as you can, because these patients will get septic. If it's not, you can be as aseptic as you want, and you can be a fantastic nurse, or, you know, and have wonderful staff and do all the aseptic technique that you want, but the sepsis can still come from COVID itself. So the blood pressure will drop, and even if it's not from the sepsis, it may come from the high PEEP value that you're putting into the patient, causing intense pressure into the right heart, so stuff like that. But where was I? Yes, so when the anesthesiologist was putting in the central line, she couldn't get that the lines to flush, even though she had everything all perfectly on the ultrasound, and we all confirmed it, and she took a picture of it. But anyway, so she finally did it a second time, and she said that's never happened to her before, and she wondered if it was a pulmonary edema. And, you know, I did remember the D-dimer was 12, and we were only giving around 20 milligrams of Lovenox once a day. I don't know if that's enough. Remember the nurse said that when we did turn her to one side, she became very, very hypoxic, and her oxygen saturation went very, very low, but more lower than usual. So, little things that I'm learning as I gain a little bit more experience with COVID. So I hope to share this with you guys. I'm off to work again. I'll talk to you guys